Good day. Today we are tackling gynecologic emergencies, abnormal uterine bleeding, and pelvic inflammatory disease. Abnormal uterine bleeding is an overarching term that is defined as bleeding from the uterine corpus that is irregular in volume, frequency, or duration in the absence of pregnancy. Vaginal bleeding is a common complaint in the emergency setting, and differential diagnoses include pregnancy, structural abnormalities such as polyps and fibroids, endometritis, coagulopathies, trauma, and various other causes. The prevalence of abnormal bleeding is estimated at 9 to 14% in the general population. Although vaginal bleeding may present as an acute or chronic problem, this will focus on the emergency evaluation and management of abnormal uterine bleeding. The normal menstrual cycle is 28 days and is divided into four phases: menses, follicular, ovulation, and luteal or secretory. The FIGO terminology for bleeding involves the following types. Abnormal uterine bleeding is bleeding that is abnormal in regularity, volume, frequency, or duration. Bleeding may be acute or chronic and is present for at least 6 months. Heavy menstrual bleeding, that is, heavy uterine bleeding replaces menorrhagia, is excessive menstrual bleeding that interferes with a woman's physical, emotional, social, and quality of life. Note that the definition is menstrual bleeding deemed excessive by the patient regardless of duration, frequency, or timing. Amenorrhea is bleeding that is absent for more than 6 months. Prolonged menstrual bleeding is menstrual bleeding that is absent for 6 months or more. Intermenstrual bleeding, which replaces metrorrhagia, are bleeding episodes between normally timed menstrual periods. Irregular menstrual bleeding is unpredictable onset of menses with a cycle variation greater than 20 days over a period of 1 year. Postmenopausal bleeding is any bleeding that occurs more than 12 months after cessation of menstruation. In response to rising estrogen levels, the pituitary gland secretes follicle stimulating hormone and luteinizing hormone, which stimulates the release of the mature oocyte. The residual follicular capsule forms the corpus luteum. During the luteal phase, the corpus luteum secretes estrogen and progesterone, which maintains the integrity of the endometrium and makes it more receptive to implantation. If fertilization and implantation occur, the developing embryo secretes human chorionic gonadotropin into the bloodstream, signaling the corpus luteum to continue the production of progesterone and estrogen necessary to support early pregnancy. In the absence of human chorionic gonadotropin, the corpus luteum involutes and estrogen and progesterone levels fall. Hormonal withdrawal causes vasoconstriction in the spiral arterioles of the endometrium. As a consequence, the ischemic endometrial lining becomes necrotic and slows, which leads to menses. The vaginal effluvium contains blood, endometrial tissue, and fluid. The average amount of menstrual blood loss ranges from 25 to 60 milliliters. The average tampon or pad absorbs 20 to 30 milliliters of vaginal effluent. However, judging the amount of blood loss by usage may be unreliable because personal habits vary greatly among women. In women with heavy bleeding, there may be insufficient time for fibrinolysis, so blood clots form. We obtain a focused medical history, which includes details of the current bleeding episode, associated symptoms, and past medical history, including reproductive and sexual history. Pregnancy related bleeding should always be considered and ruled out in reproductive age patients. Patients may describe heavy bleeding as soaking off more than one pad or tampon within 1 hour or passing large clots. Up to 20% of women with heavy uterine bleeding have an underlying coagulation disorder, with von Willebrand's disease being the most common. Screening for history of heavy menstrual bleeding since menarche, postpartum hemorrhage, surgery, or dental related bleeding, and family history may help guide further evaluation for bleeding disorders. It is also important to ask about oral contraceptive use because missed doses are a frequent cause of bleeding. Questions about drug interactions and smoking are also important in determining the cause of bleeding. To obtain an accurate sexual history from an adolescent patient, assure physician confidentiality and maintain a non-judgmental attitude. If a female physician is requested, try to honor the request if at all possible. Always ask the parents for an opportunity to interview the patient without the parent present. The initial assessment includes evaluation of vital signs and hemodynamic status. However, significant signs of volume depletion may not be present until bleeding is profuse. We perform a focused physical examination, including pelvic, via speculum and bimanual exam, and abdominal exam to determine the cause of bleeding and exclude life-threatening blood loss requiring emergent surgical intervention. We look for signs of other illnesses, including hyper and hypothyroidism, galactorrhea, obesity associated with hirsutism, and liver disease. Petechiae, purpura, and mucosal bleeding require hepatologic investigation. For pelvic examinations in the emergency room, both male and female physicians are equally advised to have a chaperone present. Decisions regarding parent or guardian presence during examination of adolescents depend on the patient's age and maturity level. Inspect the perineum, vulva, urethra, and perianal region before internal speculum exam. Evaluate the vaginal canal and cervix for lacerations, fissures, lesions, infection, tumors, and foreign bodies. On bimanual examination, determine the softness and patency of the cervical os and ask about pain on cervical movement. Palpate the uterus and adnexa for size, consistency, tenderness, and masses. In a virginal patient, a rectovaginal digital examination is generally sufficient. In the case of trauma, concern for sexual abuse, or vaginal foreign body, a vaginal examination is necessary. Adolescents with an intact hymen can generally tolerate a speculum examination if a narrow Peterson type adolescent or Huffman pediatric speculum is used. Conscious sedation or full anesthesia may be required depending on the psychological response of the patient, circumstances, and the extent of the injury or disease. Several techniques may help facilitate performing a pelvic examination in elderly women, including using a smaller speculum with general lubrication and proper positioning. Age, immobility, and degenerative joint disease may make it difficult to place the patient in the dorsal lithotomy position. Patients may be positioned supine, with the head supported with a pillow and with knees flexed and with the hips externally rotated in a frog-like position. The pelvis may be elevated using padding or an upside-down bed pad. If vaginal bimanual examination cannot be performed due to vaginal atrophy, a recto-abdominal approach may be attempted. Abnormalities such as irregular nodules, masses, or thickened rectovaginal septum may suggest malignancy. The causes of vaginal or uterine bleeding that is abnormal in non-pregnant females are classified into structural and non-structural causes using the PALM coin acronym. This stands for polyp, adenomyosis, leiomyoma, malignancy and hyperplasia, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not otherwise classified. Causes of bleeding based on age are as follows. For adolescents, anovulation through hypothalamic pituitary ovarian immaturity, pregnancy, exogenous hormones or OCPs, coagulopathy, and pelvic infections. For patients of reproductive age, pregnancy and ovulation via PCOS, exogenous hormone use or OCP, uterine leiomyomas, cervical and endometrial polyps, and thyroid dysfunction. For perimenopausal women, anovulation, uterine leiomyomas, cervical and endometrial polyps, and thyroid dysfunction. And for postmenopausal women, atrophic vaginitis, exogenous hormone use, endometrial lesions including cancer, and other tumors such as vulvar, vaginal, and cervical. The term abnormal uterine bleeding encompasses all causes of abnormal bleeding in non-pregnant women, and the most likely causes are largely determined by patient age. Because the first clinical signs of heavy menstrual bleeding are noted after the onset of menses during early adolescence, structural causes are uncommon. Anovulatory and bleeding disorders are most common during ages 13 to 19. Pregnancy-related complications become the most common cause of abnormal vaginal bleeding during reproductive years. Abnormal uterine bleeding as a result of local structural pathologies such as polyps and fibroids is typically not seen until women reach their mid-30s. Perimenopausal and ovulatory bleeding is typically seen in the mid to late 40s. Postmenopausal bleeding is often related to atrophic vaginitis, exogenous hormones, and malignancy. So when doing our history taking for patients with abnormal uterine bleeding, we look at their reproductive history, particularly the age of menarche, menstrual history, date of the last menstrual period, pattern of normal and abnormal bleeding or discharge, and the presence of dysmenorrhea. For sexual history, we look at current sexual activity, contraception, use of barrier protection, whether the patient is pregnant, gravidity and parity, previous abortion or recent termination, history of ectopic pregnancy, pelvic inflammatory disease, sexually transmitted diseases, human immunodeficiency virus, and hepatitis status. We also look at the history of trauma, possibilities of retained foreign body, medications including alternative and complementary medicine, and past medical history, which includes signs and symptoms of coagulopathy, including nosebleeds, petechiae, and ecchymosis, endocrine disorders, including diabetes, pituitary tumors, polycystic ovarian disease, hyperthyroidism and hypothyroidism, liver disease, and associated symptoms in the urinary, gastrointestinal, musculoskeletal systems, and fever or symptom. Let's begin with the structural causes of vaginal bleeding. Endometrial and endocervical polyps are epithelial proliferations that are most often benign. Although most polyps are asymptomatic, polyps can be a cause of abnormal uterine bleeding in women older than 35 years. A common symptom is intermenstrual bleeding, and diagnosis is made on hysteroscopy. Adenomyosis is the presence of endometrial glands and stroma within the myometrium. The histopathology is often diffuse within the uterus, but localized areas of growth are called adenomyomas. Symptoms include painful, heavy periods, most commonly seen in the fourth and fifth decade of life. Emergency management is aimed at symptomatic treatment, analgesics, and evaluation for anemia. Euprolide acetate, a gonadotropin-releasing hormone analog, plus add-back therapy or a levonorgestrel intrauterine device for 6 months may be initiated as outpatient. MRI is the imaging modality of choice, but ultrasound is a good alternative. Patients with severe bleeding unresponsive to medical management often require surgical management. Uterine fibroids, also called leiomyoma or myoma, are the most common benign tumors of the pelvis in women. The cause is unclear, but fibroid growth is dependent on genetic factors and hormones. Gonadotropin-releasing hormone, estrogen, and progestin. Leiomyomas decrease in size during menopause. In some cases, fibroids will enlarge early in pregnancy and with oral contraceptive pill use. Most fibroids are asymptomatic, but up to 30% of patients with leiomyomas experience pelvic pain and abdominal bleeding. Acute pain is rare, but severe pain may be experienced with torsion or degeneration. Degeneration results from rapid growth and loss of blood supply, often seen during early pregnancy. A rare case of spontaneous fibroid rupture causing massive intra-abdominal hemorrhage has been reported in the literature. Signs and symptoms of fibroids vary depending on fibroid size and location. Large fibroids may be palpated on abdominal or rectal exam. Symptoms of acute degeneration include tenderness, rebound guarding, fever, and elevated WBC count. Pedunculated subserosal leiomyomas may undergo torsion or cause uterine cramping. Rapid growth at any age or growth after menopause is highly suspicious for malignant transformation. The best diagnostic test is ultrasonography, and it is as sensitive as MRI. The management of uterine fibroids depends on the severity and duration of symptoms. In the emergency room, management is focused on treating complications associated with fibroids. Iron deficiency anemia is often long-standing and may require blood transfusion. Other complications are rare, but constipation, urinary retention, vaginal or intraperitoneal hemorrhage, deep vein thrombosis, and mesenteric thrombosis have been reported. NSAIDs are the mainstays for analgesia. Medical management with hormonal agents may be initiated in the emergency setting with gynecologic consultation. Intrauterine fibroids are treated surgically with hysteroscopy. Surgical removal is associated with a 25 to 30% rate of recurrence and significant bleeding complications. Uterine artery embolization is an effective treatment for symptomatic fibroids, resulting in decreased fibroid volume and alleviation of symptoms. Any malignancy of the genital tract, in particular endometrial or cervical cancer, may produce bleeding. Consider endometrial hyperplasia or endometrial cancer in women older than 45 years old or in younger women with other risk factors. The amount of bleeding does not correlate with the severity of the disease. Elderly patients may not be able to accurately describe the location of pain or bleeding in the proximity of the bladder, uterus, or rectosigmoid. Therefore, make sure to adequately visualize the vagina and cervix on pelvic examination. All patients with postmenopausal bleeding warrant prompt referral for evaluation. Outpatient ultrasound and endometrial biopsy should be arranged for stable patients. Vaginal bleeding, especially when seen in conjunction with atrophic vaginitis, may be associated with the use of pessaries and douche solutions, which can irritate the mucosa. Cervical polyps can also cause vaginal bleeding. However, an endometrial biopsy is ultimately required to rule out other serious causes of bleeding. So, when we look at factors frequently used to determine the cause of abnormal bleeding in perimenopausal women, we look at associated hot flashes, which are present in perimenopause only, increased cramping, which is most common in adenomyosis but can also be seen in neoplasia and fibroids, bleeding pattern with skips and misses, more common in perimenopause, sometimes in neoplasia, amenorrhea in perimenopause, and pregnancy-related bleeding, regular but heavy bleeding in fibroids, adenomyosis, and polyps, irregular in perimenopause, polyps, and pregnancy-related, since polyps can cause intermenstrual bleeding. For physical examination, the uterus is enlarged in fibroids and adenomyosis, and also in pregnancy. The uterus is enlarged and tender in adenomyosis. In ultrasonography, the uterus is enlarged in fibroids and adenomyosis, and intrauterine masses may be present along with enlargement of the uterus in polyps and pregnancy-related bleeding. For laboratory tests, follicle stimulating hormone is elevated in perimenopause. A complete blood count is usually normal or low in neoplasia, fibroids, adenomyosis, polyps, and pregnancy-related bleeding. And human chorionic gonadotropin is only positive in pregnancy-related bleeding. So there are also non-structural causes of vaginal bleeding, the coin part of the acronym earlier. So we consider these causes in the differential diagnosis by methodical history and physical examination. We pursue as needed with further investigations and consultations. Primary coagulation disorders account for 5 to 20% of acute uterine bleeding in adolescents. Von Willebrand's disease is the most common cause, but myeloproliferative disorders and immune thrombocytopenia may also be diagnosed. In adults, bleeding may result from anticoagulation agents or acquired bleeding disorders. Cirrhosis may lead to bleeding secondary to reduced capacity of the liver to metabolize estrogens. In ovulatory dysfunction, acute uterine bleeding secondary to anovulation is seen in 10 to 15% of gynecologic patients. Signs include irregular and or heavy menstruation. Ovulatory dysfunction is common in perimenarchal and perimenopausal women, as well as in patients with endocrine disorders, polycystic ovary syndrome, exogenous hormone use, and liver or renal disease. Anovulatory uterine bleeding in adolescents is due to the immature hypothalamic pituitary ovarian axis. In this situation, the amount of bleeding is usually minimal and painless. Dilatation and curettage is rarely required. Severe anemia from heavy menstrual bleeding in early adolescence should prompt evaluation for bleeding disorders like von Willebrand's disease and factor VIII deficiency. The medical management of acute uterine bleeding from ovulatory dysfunction is as follows. We can use conjugated equine estrogen or Premarin with a suggested dose of 25 milligrams intravenously every 4 to 6 hours for 24 hours, with contraindications being breast cancer, liver disease, venous thromboembolism. We can also use combined oral contraceptives with 0.25 milligrams of norgestrel and 0.035 milligrams of ethinyl estradiol, usually a monophasic combined OCP that contains at least 35 micrograms of ethinyl estradiol 3 times per day for 7 days, contraindicated in smokers, people who are older than 35 years old, hypertension, venous thromboembolism, cerebrovascular accident, breast cancer, liver disease, thromboembolic disorders, diabetes with vascular disease, heart disease, and major surgery with immobilization. And medroxyprogesterone acetate can be given 20 milligrams orally 3 times per day for 7 days with contraindications of VTE, liver disease, and breast cancer. Anovulatory bleeding in the reproductive age female may be regular in timing, but more often irregular because of fluctuating estrogen levels below the critical level required to maintain endometrial growth. The level of estrogen depends on age, number, and activity of ovarian follicles. As some follicles degenerate, Others resume production of estrogen, and the endometrium continues to proliferate for weeks to months, which may cause glandular hyperplasia or Swiss cheese hyperplasia. The estrogen steady state is insufficient to meet the growing needs of the endometrium and produces a relative estrogen insufficiency, and uterine bleeding ensues. Alternatively, when follicle degeneration and stimulation are not balanced, absolute estrogen levels fall and withdrawal bleeding occurs. Characteristically, anovulatory cycles present as prolonged amenorrhea with periodic menorrhagia. Because of the lack of progesterone-mediated myometrial contractions and arteriolar vasospasm, anovulatory cycles are rarely associated with cramping. This pattern of bleeding increases the risk of endometrial hyperplasia and adenocarcinoma. Hypothyroidism may be associated with heavy uterine bleeding or intermenstrual bleeding from ovulatory dysfunction with an estimated incidence of 0.3 to 0.5%. Eating disorders, excessive weight loss, stress, and exercise can also cause abnormal uterine bleeding. The obtained levels of thyroid stimulating hormone in women with uterine bleeding of undetermined origin or those with thyroid nodule or goiter. Acute uterine bleeding that occurs in the context of normal ovulation with a structurally normal endometrial cavity is attributed to endometrial causes. Normal ovulation is based on a history of predictable cyclical menstrual periods. Bleeding may be preceded by breast tenderness, abdominal bloating, and pelvic pain. The diagnosis is made when patients have heavy menstrual bleeding with no other identifiable abnormalities. Ovulatory bleeding is generally treated with oral contraceptives, NSAIDs, or progestins. Endometrial ablation may be useful for those who do not respond to medical therapy, and hysterectomy is reserved for those who fail medical management and have excessive blood loss. For iatrogenic causes, oral contraceptive pills remains the most common cause of intermenstrual bleeding. Additionally, medications, especially anti-seizure medications that increase the cytochrome P450 system of the liver, may increase the metabolism of endogenous hormonal glucocorticoids and may cause withdrawal bleeding. Hormone replacement therapy, which can relieve symptoms associated with menopause, may also be associated with vaginal bleeding. Hormone replacement therapy for this purpose has been called into question as there is no clear benefit for primary and secondary prevention of cardiovascular disease and excessive risk of endometrial, breast, and colorectal cancer and thromboembolism has been noted. 40% of women receiving continuous OCP therapy will experience abnormal bleeding in the initial 4 to 6 months. Bleeding after 6 months of continuous combined hormone replacement therapy, unexpected bleeding with cyclic hormone replacement therapy, or bleeding that occurs after amenorrhea is established should prompt referral for evaluation. There are no acceptable criteria for abnormal bleeding on these therapies. The most common etiologies for bleeding while on hormone replacement therapy are poor compliance, poor gastrointestinal absorption, drug interactions, failure to synchronize therapy with endogenous ovarian activity, and coagulation disorders. Other causes of vaginal bleeding include pelvic inflammatory disease, which will be discussed later, or infections that cause endometritis. Cervical erosions, polyps, and cervicitis may cause bleeding from the cervix. Vaginal infections, trauma, and foreign bodies may also present with abnormal bleeding. Emergency therapy should be directed at investigating and treating all these causes of bleeding. For laboratory evaluation and imaging, we obtain a pregnancy test in women of childbearing age, except those with hysterectomy, to rule out pregnancy as a cause of bleeding. CBC identifies anemia. We only obtain coagulation studies when indicated by history or physical examination. In individuals with suspected endocrine disorders, determination of thyroid stimulating hormone and prolactin levels may be helpful, but these levels may not be available for emergency room evaluation. Ultrasonography is the first-line imaging modality for gynecologic conditions such as vaginal bleeding, adnexal or uterine masses, or pelvic pain. Ultrasound can determine uterine size and endometrial characteristics and can identify the presence of leiomyoma, ovarian cysts, hydrosalpinx, pelvic adhesions, tubo-ovarian abscesses, endometriosis, and tumors. Transvaginal ultrasonography further delineates ovarian cysts and fluid in the cul-de-sac. Depending on the degree of pain and findings in physical examination, ultrasound can be done on an emergency basis or deferred for outpatient evaluation. Patients who are hemodynamically unstable need immediate resuscitation and emergent gynecologic consultation. Do not attempt vaginal packing because it increases the risk of infection and may hide ongoing blood loss. In addition to fluid resuscitation, blood transfusion, and correction of underlying coagulopathies Assess for other potential causes of bleeding, including trauma, bleeding discourages, infection, and retained foreign bodies. The options for management of acute hemorrhage include hormonal, surgical, and hemostatic interventions. Perimenopausal women with abnormal uterine bleeding should have an endometrial biopsy before the initiation of hormone replacement therapy. Otherwise, hormonal agents are the first line medical management for acute uterine bleeding in patients without an underlying bleeding disorder. Short term hormonal treatment allows the endometrium to stabilize and slows acute bleeding. Acute treatment options include intravenous estrogen and oral progestins. For severe hemorrhage, give conjugated estrogen at a dose of 25 milligrams IV every 4 to 6 hours until bleeding stops with observation, followed by an oral contraceptive. In women with a history of blood clot or cardiovascular disease, high dose estrogen therapy is contraindicated. Progestin is used when there is concern for underlying endometrial pathology or hyperplasia. Ultrasound findings may reveal a thickened endometrial strip, fibroids, or polyps. Tranexamic acid, a lysine derivative that prevents fibrin degradation, is used primarily for intraoperative gynecologic bleeding. Use depends on geography and institution, so obtain gynecologic consultation if administration is considered, especially to discuss risks and benefits. Clinical studies on the effectiveness of tranexamic acid have excluded patients with potential for thrombosis. Heavy menstrual bleeding is treated with NSAIDs and combined or progestin-only oral contraceptives. Progesterone works by decreasing the number of available estrogen receptors and stabilizing the endometrium. Common side effects of this regimen include nausea and vomiting. One recent report recommended IMD medroxyprogesterone combined with a short 3-day oral course of an oral contraceptive with a mean time of bleeding cessation for 2.6 days, and all patients stopped bleeding within 5 days. However, multiple different hormonal doses and schedules are also effective. In general, for young, healthy women where bleeding is often related to an ovulation and there is no concern for endometrial pathology, OCPs are favored. For older patients or obese perimenopausal patients where there could be concern for endometrial pathology, then progestin only is preferred. For long-term management, it is essential to establish a definitive diagnosis before initiating long-term management. Expected management is appropriate if episodes of heavy or irregular bleeding are infrequent. Several choices for long-term medical management of heavy menstrual bleeding exists. OCPs being one of them, usually for adolescents and women requiring contraception with heavy menstrual bleeding decreased by 50% with a similar reduction in the degree of pain associated with bleeding. NSAIDs are effective in reducing pain and blood loss in 20 to 50% of women with abnormal uterine bleeding secondary to ovulatory dysfunction. Should be started on the first day of the period and continued until bleeding stops and pain resolves. All NSAIDs inhibit cyclooxygenase in the arachidonic acid cascade. Prostaglandin inhibitors alter the ratio of prostaglandin F2 alpha, which causes vasoconstriction, to prostaglandin E2, which causes vasodilation. NSAIDs also increase the levels of thromboxane A, which causes vasoconstriction and increases platelet aggregation. NSAIDs have a mild side effect profile and they're inexpensive. Treatment choices include mefenamic acid, 500 milligrams 3 times a day, naproxen, 500 milligrams twice per day, and ibuprofen, 400 milligrams every 6 hours. All these may be administered, well, any of them to reduce bleeding and pain associated with the use of an intrauterine device. They are less useful in patients with uterine adenomas. Clomiphene citrate, medroxyprogesterone acetate, gonadotropin-releasing hormone agonists, and oxalic acid are additional long-term treatment options. Clomiphene citrate may be used to decrease bleeding as well as to induce ovulation if pregnancy is desired. If no contraindication to progestin usage, medroxyprogesterone acetate, 10 milligrams daily per arm for 10 days can be used to produce scheduled bleeding. Intrauterine progesterone release is a highly effective treatment option. Patients may still ovulate when using this medication. Gonadotropin releasing hormone agonists may be used to induce amenorrhea, but women on this therapy become menopausal. Other drawbacks include medication expense and wound loss when used for more than 6 months. Tranexamic acid, a fibrinolytic, reduces vaginal bleeding with minimal side effects. Non-medical invasive management strategies may be required if medical treatment fails. These include hysteroscopy, endometrial ablation, or myelectomy. Hysteroscopy can be used to sample the endometrium and resect polyps and myoma. Endometrial ablation may be performed in patients who do not desire fertility, have no pathologic diagnosis, and for whom medical therapy has failed. Myomectomy may be useful in patients with symptomatic fibroids. Hysterectomy is reserved for selected patient populations. Uterine artery embolization is an effective non-surgical option for the management of bleeding caused by fibroids. So there are special populations we have to keep in mind here, such as those with genital trauma. Vaginal injuries after intercourse are not uncommon. The majority of coital injuries result from vigorous voluntary sexual activity, although violent involuntary sexual activity should also be considered. The most common site of injury is the posterior vaginal cortex. Misdiagnosis of coital injuries occurs frequently because either the physician fails to take an adequate history or the patient does not admit to antecedent sexual activity. Most coital injuries are minor, but severe injuries may lead to hemorrhagic shock. Bleeding disorders may also become apparent with an initial presentation of abnormal menstrual bleeding. Uterine hemostasis is not well understood, and any disorder of blood vessels, platelet abnormalities, and coagulation disorders, including von Willebrand's disease, may result in excessive menstrual bleeding. Polycystic ovary syndrome, which is one of the most common endocrine disorders, is the association of hyperandrogenism and anovulation without underlying disease of the adrenal or pituitary glands. A triad of obesity, hirsutism, and oligomenorrhea is classically described, although obesity is not universally seen. When menses occurs, it is heavy and prolonged. The syndrome is further characterized by acne, androgen-dependent alopecia, elevated serum concentrations of androgens, hyperinsulinemia, and hypersecretion of luteinizing hormone with a normal or low follicle stimulating hormone level. Typical ovarian morphology, which may be seen by ultrasound, is not necessary for the diagnosis and may in fact represent a response of the ovary to and ovulation. The differential diagnosis includes hyperprolactinemia, acromegaly, congenital adrenal hyperplasia, and androgen-secreting tumors of the ovary or in the adrenal gland. Management of menorrhagia in women who do not desire fertility includes low-dose oral contraceptives or cyclic progestin administration. And for patients with human immunodeficiency virus, there is no need to change the approach to vaginal bleeding in women who are positive for retrovirus infection. We look for associated infections and complications of chronic illness. And for those with stress, illness, and rapid weight changes, periods of physical or psychological stress, illness, malnutrition, rapid weight gain or loss, and intense physical regimens affect the hypothalamus and disrupt the normal pattern of gonadotropin release. This usually causes amenorrhea but may result in irregular, heavy bleeding. In obese women, menorrhagia may be a result of increased circulating levels of estrogen from the peripheral conversion of androstenedione to estrone in fatty tissue. Patients with liver and renal disease may also develop irregular bleeding. So now let's go on to pelvic inflammatory disease. This term comprises a spectrum of infections of the female upper reproductive tract. It is a common and serious disease initiated by ascending infection from the vagina and cervix. PID includes salpingitis, endometritis, myometritis, perimetritis, oophorytis, and tubovarian abscess, and may extend to produce periappendicitis, pelvic peritonitis, and perihepatitis, also known as the Fitzhugh-Curtis syndrome. PID is the most common serious infection in sexually active women aged 16 to 25 years. Long-term sequelae, including tubal factor infertility, implantation failure after in vitro fertilization, ectopic pregnancy, and chronic pain, may ultimately affect 11% of reproductive age women. The most common cause of death is rupture of a tubal ovarian abscess, and the mortality associated with rupture remains at 5 to 10%, even with current treatment methods. Organisms associated with PID include Neisseria gonorrhoeae and Chlamydia trachomatis. They can be isolated in many cases of PID, and therapy is directed primarily against these organisms. However, polymicrobial infection, including infection with anaerobic and aerobic vaginal flora, is evident from cultured material from the upper respiratory tract. So, other organisms associated with pelvic inflammatory disease include herpes simplex virus, types 1 and 2, and Trichomonas vaginalis, as well as endogenous genital tract mycoplasma such as M. genitalium, M. hominis, and Ureaplasma urinae. and anaerobic bacteria such as the Bacteroides species, Peptostreptococcus, Prevotella bibia, Leptotrichia sanguinigens, Amnioni, Aptobium virginale, and aerobic bacteria such as Gardnerella vaginalis, Haemophilus influenzae, Streptococcus agalactiae, Escherichia coli, and other gram-negative rods such as Actinomyces israeli and Campylobacter vigus. Bacterial vaginosis is frequently identified in women with PID, and the type of bacterial vaginosis associated microorganism, be it Gardnerella, Mycoplasma, or Ureaplasma, pigmented or non-pigmented anaerobic gram-negative rods may make a difference in the likelihood of developing PID. Infection with Trichomonas vaginalis is associated with a fourfold increase in the incidence of acute endometritis. Co-infection with herpes simplex virus 2 and C. trachomatis and gonorrhea or bacteria-causing vaginosis is also associated with acute endometritis. Infection with herpes simplex virus 2 causes fallopian tube inflammation and lower tract ulceration that may disrupt the endocervical canal mucous barrier. HIV-1 infection is associated with an increased incidence of C. trachomatis infection, increased incidence of co-infection with Candida and human papillomavirus, and increased risk of progression to PID. PID may result from Mycobacterium tuberculosis infection in endemic areas. Schistosomes can cause genital infection, including a PID-like tubal infection, infertility, and chronic abortion, and a recent report links schistosomiasis to HIV transmission in Africa. Actinomyces species have been identified almost exclusively in patients with intrauterine devices. For ascending infection, most cases of PID are presumed to originate with sexually transmitted infections of the lower genital tract, followed by ascending infection of the upper tract. The original STI may be asymptomatic. The precise mechanisms by which upper genital tract infection and inflammation are initiated and propagated are not known. Although cervical mucus serves as a functional barrier to ascending infection much of the time, its efficacy may be decreased by hormonal changes during menstruation and ovulation and by retrograde menstruation. Intercourse may contribute to the ascent of infection due to rhythmic mechanical uterine contractions. Bacteria may also be carried by or along with sperm into the uterus and tubes. Uterine infection is usually limited to the endometrium but can be more invasive in a gravid or postpartum uterus. Tubal infection initially affects only the mucosa, but acute complement-mediated transmural inflammation may develop rapidly and increase in intensity with repeated infection. Inflammation may extend to uninfected parametrial structures, including the appendix and bowels. Infection may spread by direct extension of the purulent material from the fallopian tubes or via lymphatic spread beyond the pelvis to involve the hepatic capsule with acute perihepatitis, also known as Fitzhugh herpes syndrome, and produce acute peritonitis. Risk factors associated with pelvic inflammatory disease include multiple sexual partners, a history of sexually transmitted infection or pelvic inflammatory disease, a history of sexual abuse, frequent vaginal douching, intrauterine device insertion within the previous month, adolescence, younger adulthood, lower socioeconomic status, and post-abortal learning. IUD use has been associated with an increased risk for PID. Although the majority of risk occurs within 21 days of insertion, the presence of an IUD is associated with complicated PID irrespective of the duration of use. The risk of PID in IUD users is more related to the development of sexually transmitted infections than the IUD, and STI screening and treatment at the time of insertion can significantly decrease the likelihood that PID will develop. Pregnancy decreases the risk of PID because the cervical os is protected by the mucus plug. However, PID can occur during the first trimester and is associated with substantial fetal loss on preterm delivery. PID is associated with a number of serious clinical sequelae. Tubo-ovarian abscess is reported in up to one-third of women hospitalized for PID. Infection and inflammation can lead to scarring and adhesions within the tubal lumen. Ectopic pregnancy is more frequent in women who have had PID than in those who have never had an ectopic pregnancy. Tubal factor infertility is increased by 12 to 50% in women with a past diagnosis for PID, and the incidence increases with the number and severity of past PID episodes. Asymptomatic or silent PID appears to be associated with tubal factor infertility as well. Sequelae of PID include recurrence of PID, chronic pelvic pain, menstrual disturbances, and chronic dyspareunia. Recurrence of PID may occur because of inadequately treated infection, non-treatment of the partner, or reinfection from another sexual contact. The clinical presentation of PID is variable. The most common presenting complaint is lower abdominal pain, most frequently described as bilateral and dull or crampy. Pain may be exacerbated by movement or by sexual activity. Other symptoms include abnormal vaginal discharge in 75% of individuals, vaginal and postcoital bleeding in more than one-third of patients, irritative voiding symptoms, fever, malaise, nausea, and vomiting. Symptoms occur most commonly early in the menstrual cycle or at the end of menses and are attributed to low progesterone levels and coincident thinning of the cervical mucosal barrier. The physical examination is usually notable for lower abdominal tenderness, cervical motion tenderness, and uterine or adnexal tenderness. Involuntary guarding and rebound tenderness may be present and may indicate associated peritonitis. The positive predictive value of these findings varies depending on the prevalence of PID in the given clinical population. Adnexal tenderness appears to have a sensitivity of 95%. Mucopurulent cervicitis is a common finding, and its absence should raise consideration of another diagnosis. In women who are suspected of having PID and for whom there is no likely alternative diagnosis for abdominal pain, the presence of fever, adnexal tenderness, and an elevated erythrocyte sedimentation rate are significant independent predictors of endometritis and correctly classify 65% of patients with laparoscopically proven PID. Right upper quadrant tenderness, particularly with jaundice, may indicate perihepatic inflammation. Fitzhugh-Curtis syndrome is perihepatitis demonstrated by right upper quadrant pain in a woman with a clinical diagnosis of PID and no other cause for this pain. It is an uncommon complication and responds to standard antibiotic treatment for PID. The differential diagnosis of PID is broad and includes cervicitis, ectopic pregnancy, endometriosis, ovarian cysts, ovarian torsion, spontaneous abortion, septic abortion, polycystitis, gastroenteritis, appendicitis, diverticulitis, pyelonephritis, and renal colic. Look for signs of other sexually transmitted infections such as herpes simplex, syphilis, and human papillomavirus infection. The diagnosis is based on history and clinical findings. There's no single piece of historical, physical, or laboratory information sensitive and specific for the disease. Laboratory evaluation of any woman of childbearing age should always include a pregnancy test. We consider the possibility of ectopic pregnancy or septic abortion. The most common alternative diagnosis in this ectopic pregnancy is PID. Confirmed pregnancy also influences patient treatment and disposition. So the diagnostic criteria for pelvic inflammatory disease is as follows. Minimum criteria with empiric treatment if there's no other cause to explain findings is uterine or adnexal tenderness and cervical motion tenderness. For group 2, this is additional criteria including diagnostic specificity, such as an oral temperature of greater than 38.3, abnormal cervical or vaginal mucopurulent secretions, elevated erythrocyte sedimentation rate, elevated C-reactive protein level, laboratory evidence of cervical infection with Neisseria gonorrhoeae or chlamydia trachomatis, and the last group is specific criteria for PID based on procedures that may be appropriate for some patients, such as laparoscopic confirmation, transvaginal ultrasound or MRI showing thickened fluid-filled tubes with or without free pelvic fluid or a tubal ovarian complex, and endometrial biopsy results showing endometritis. For our laboratory testing, we obtained saline and potassium hydroxide treated wet preps of vaginal secretions to identify leukorrhea, which is more than one polymorphonuclear leukocyte per epithelial cell, and trichomonads, and to test for bacterial vaginosis, including flu cells, pH, and the whiff test. Leukorrhea is sensitive but not specific for upper tract infection, and the absence of leukorrhea is a negative predictor for PID. Although endocervical swab specimens may be sent for culture and can be gram-stained for gonococci, nucleic acid amplification tests and DNA probes for gonorrhea and chlamydia have replaced culture and gram staining in these settings. If PID is clinically suspected, an elevated WBC count, erythrocyte sedimentation rate, or C-reactive protein level supports the diagnosis. Because a patient may have multiple sexually transmitted infections, we also obtain a rapid plasma reading test for syphilis. Test for HIV and hepatitis. Urinalysis can exclude urinary tract infection, but a positive urinalysis does not exclude PID because any inflammatory process in the contiguous pelvis can produce WBCs in the urine. Blood cultures do not aid in diagnosis or treatment. Transvaginal pelvic ultrasound may demonstrate a thickened, more than 5 millimeters, fluid-filled fallopian tubes or free pelvic fluid in acute severe PID. Pelvic or tubo-ovarian abscesses appear as complex adnexal masses with multiple internal envelopes. Pelvic ultrasound can demonstrate as many as 70% of adnexal masses missed on physical examination. Ultrasound may also be helpful in ruling in or out other causes in the differential diagnosis of pelvic pain, including ectopic pregnancy, ovarian torsion, hemorrhagic ovarian cyst, and possibly appendicitis or endometriosis. Abdominopelvic CT scan and MRI may also be used in the diagnosis of PID and the exclusion of other important causes of pelvic pain. If appendicitis or other surgical or gastrointestinal diagnosis cannot be excluded, obtain an abdominal pelvic CT. CT findings in PID include obscuration of the pelvic fascial planes, cervicitis, ophoritis, salpingitis, thickening of the uterosacral ligaments, and the presence of simple or complex pelvic fluid or abscess collections. MRI is especially helpful in characterizing complicated soft tissue masses, including dilated fallopian tubes and abscesses. MRI imaging is more specific and accurate than ultrasound to assess PID with a sensitivity of 95% and a specificity of 89%. Treatment is aimed at relieving acute symptoms, eradicating current infection, and minimizing the risk of long-term sequelae. From a public health perspective, another objective of treatment is to reduce the risk of transmission of infection to other new partners and to identify and treat past and current sexual partners to prevent disease spread. Early diagnosis and treatment are critical because duration of symptoms is an independent risk factor for infertility. Provide adequate analgesia, control of emesis and fever, and fluid replacement in those with nausea, vomiting, and dehydration in those who appear toxic. Nonsteroidal anti-inflammatory drugs are very useful for the management of pain of pelvic origin. Emergency treatment should include empiric broad-spectrum antibiotic therapy to cover the full range of likely organisms. Screen for bacterial vaginitis and treat when screening is positive. Treatment regimen should follow guidelines in the country and parenteral treatment regimens for pelvic inflammatory disease include cefotetan 2 grams IV every 12 hours or cefoxitin 2 grams IV every 6 hours plus doxycycline 100 milligrams per orem or IV every 12 hours or clindamycin 900 milligrams per IV every 8 hours plus gentamicin 2 milligrams per kilogram IV or IM loading dose followed by gentamicin 1.5 milligrams per kilogram every 8 hours maintenance dose. And an alternative parenteral regimen with limited data on effectiveness is ampicillin sulbactam 3 grams IV every 6 hours plus doxycycline 100 milligrams per orem or IV every 12 hours. Currently accepted inpatient and outpatient treatment is summarized earlier, and now I'm going to outpatient treatment since I already did inpatient treatment. Ceftriaxone 250 milligrams IM once or cefoxitin 2 grams IM once and probenecid 1 gram per orem once administered concurrently or other parenteral third generation cephalosporins like ceftizoxime or cefotaxime plus doxycycline 100 milligrams per orem twice a day for 14 days with or without metronidazole 500 milligrams per orem twice a day for 14 days. If parenteral cephalosporin therapy is not feasible and community prevalence of fluoroquinolone resistance is low, we also use levofloxacin 500 milligrams per orem or ofloxacin 400 milligrams twice daily every day for 14 days with or without metronidazole 500 milligrams per orem twice a day for 14 days. For treatment with IUDs in place, in the past, IUDs were generally removed based on the belief that because it is a foreign body, removal of the IUD would allow treatment to be more effective. There's a low risk of PID from IUD insertion, especially when STI testing is done concomitantly and immediate treatment is initiated. So for individuals who are using IUD to develop PID, there are no data to support the use of one treatment regimen over another. Close clinical follow-up is prudent. If there's a concern regarding PID in a patient with an IUD placed in the last 3 weeks, it is reasonable to consult a gynecologist regarding removal. Microbiologically, HIV positive women are more likely to have concomitant candida, mycoplasma hominis, HPV, and streptococcal infection. HIV positive women with PID may experience more severe symptoms irrespective of CD4 count and are more likely to have sonographically diagnosed tubal ovarian abscess. However, they appear to respond similarly to treatment for uncomplicated PID as do women who are not infected with HIV. HIV positive status alone is not a criterion for hospitalization. Although HIV status has been removed from specific admission considerations, the 2010 CDC STI guidelines note that whether the management of immunodeficient HIV infected women with PID requires more aggressive interventions such as hospitalization or parenteral antimicrobial regimens has not been determined. For treatment of adolescents, early and mid adolescents were not well represented in the PID evaluation and clinical health studies. And of those enrolled, adolescents had increased risks of recurrent PID and a shorter time to pregnancy after an acute episode compared with adult enrollees. Adolescents hospitalized in pediatric centers often receive services beyond IV antibiotics, including education on risk reduction, emotional support, social work intervention, and assistance with communicating the nature of their illness with their parents, and assistance to arrange close follow up. For tubo-ovarian abscess, disproportionate unilateral adnexal tenderness or adnexal mass or fullness may indicate a tubo-ovarian abscess. In women with clinical toxicity and asymmetric pelvic findings, we obtained a pelvic ultrasound. Most tubo-ovarian abscesses, 60 to 80%, resolve with antibiotic administration alone. In the setting of tubo-ovarian abscess, oral therapy should be continued with clindamycin, 450 milligrams per orum 4 times per day, or metronidazole with doxycycline for better anaerobic coverage for 14 days. Patients who do not improve after 72 hours of treatment should be evaluated for possible CD or ultrasound-guided percutaneous drainage, laparoscopic drainage, posterior colpotomy with drainage, surgical intervention, or reconsideration of other possible diagnoses. Abscesses 9 centimeters or larger on imaging appear to have a higher likelihood of requiring surgical therapy. An enlarging pelvic mass may indicate bleeding secondary to vessel erosion or a ruptured abscess. Our reference is Tintinalli's Emergency Medicine. Thank you.